What's happening, everybody? Michael Andreula here in Richmond, Virginia. We're about to meet with Dr. Dayspring, a world-renowned lipidologist, and we're going to find out why eating a lot of fat will actually make you skinny. My name is Michael Andreula, and we're in Richmond, Virginia. We're in Dr. Dayspring's office. He's a world-renowned lipidologist. I would honestly say world-renowned. You must be among a very few lipidologists out there.
Well, you're being very kind. I am certainly a well-known lipidologist and have a bit of a bibliography behind my name, probably way more so in the United States, although I have some international experience. And to fill you in on me, I'm an MD who's actually, until very recently, has been in private practice in the state of New Jersey for 37 years. This year I had an opportunity to move to Virginia to assume the Director of Cardiovascular Education at something called the Foundation for Health Improvement and Technology, which is a nonprofit dedicated to teaching healthcare professionals and even laymen on modern aspects of atherosclerotic heart disease and how we would be better equipped to both diagnose it and treating it using more modern biomarkers. Although as a real-world internist, about 15 years ago, I had the opportunity to start doing some cardiovascular education, and lo and behold, I was somewhat successful, and boy, the number of requests for me to come in and speak here, there, and everywhere just grew, that I evolved from full-time practice to part-time practice, limited to lipid and lipoprotein sort of disasters, to now a full-time educator. And I truly believe that certainly at this stage of the game, I can probably do a lot better for the population bringing all other healthcare professionals on board than I can treating patients one at a time, although still there's great satisfaction in doing that. So I like to say I'm just a real-world internist who stumbled into a lipid, lipoprotein world and have been somewhat successful in that world. And getting involved with a lot of groups like the kickboxing group here and trying to educate their membership onto what they need to do. Certainly a group like yours, if you're going to be a serious kickboxer, you're interested in your health. So you should know many aspects of your health. And I always like to say, no matter whether you're a world-class athlete or not, the odds that line one on your death certificate is going to say arteriosclerotic heart disease is pretty good if you don't screen and take care of any silent cardiovascular risk. So I look at it as a great opportunity to share with your membership the type of ideas I promulgate on helping them take better care of themselves.
We appreciate that tremendously. One thing I have to do is rely on experts, because I can't do the studies. Even the studies I see, I can't reach out to the directors of the studies and really find out what happened, what their true belief, what their feeling was, and that's why we go to the highest possible level. And we deal with much more than kickboxers, just anyone that wants to lose weight.
Sure.
And my heart goes out to them, because I had struggled so long to lose weight and keep it off and not starve yourself. So one of the number one questions I wanted to get out, and I'm sure you're bored to death talking about this, does recommending or eating saturated fat or a high-fat diet cause heart disease?
Well, certainly that's in the Bible, isn't it?
Yes.
That's what everybody's
so
told. And the truth is, atherosclerotic heart disease, which maybe we'll get into and define a little later, is a very complex disease that has multiple things that might lead to it. If you want to simplify it, it basically comes down to the genetic set of genes you've been dealt, which you have nothing to do with, and how you expose those genes to the environment. And that environment would include what you're doing nutritionally, what you're doing exercise-wise, are you not taking some supplements or prescription drugs, you put all of that together, you may or may not have cardiovascular risk. So, through a variety of studies that many of us now believe were flawed, and anybody listening to this who hasn't read Gary Taub's book on this, please do so. We've had it drummed down our throats forever that if you eat fat, you're going to be fat and you're going to get atherosclerotic heart disease.
Clogs your arteries.
And everybody believes that. Most nutritional guidelines are still directed at low fat, including American Heart Association. But believe it or not, all the evidence that people think is gold standard, if subjected to critical analysis, a lot of it is BS. A lot of it is very weak evidence that somehow got promulgated and promulgated and promulgated. And it's just not true. There are certainly some people where their genes can't handle fat and it may put them at risk. But there are a lot of people who can actually ameliorate their cardiovascular risk by actually increasing the fat in the diet, but eliminating another substance, which those of you listening to this have probably already educated yourself a little bit about, is where do the carbohydrates fit in this picture?
Yes.
And anybody who comes along and promulgates a new idea is going to be called a fool, a charlatan, and good old Dr. Atkins certainly suffered that through most of his life when he sort of suggested maybe we ought to start eating less carbs and not worry about the fat so much. Turns out he's pretty much right for the majority of people, not everybody. So you can't just come out with a dogmatic statement that fat causes heart disease. It may in a certain percentage, but I will guarantee you our coronary care units are full, our bypass units are full from the abuse of carbohydrates in the diet. That would, if we needed to make a dramatic thing to really influence heart disease in America, it's not to put everybody in the world on a statin or any other drug. It's to analyze in you are carbohydrates contributing to your risk, and if so, and we modulate your carbohydrates, what can we do to that risk? So this is changing radically. So please ignore that statement that fat is what's behind this whole thing. It is way more complicated than that.
Perfect. And the idea of also cholesterol. Cholesterol, I mean, you must just walk down the street and have to educate every single person you meet because my cholesterol's too high. I don't want to eat that because it's going to raise my cholesterol. And I mean,
no,
every dinner party you go to.
It's very easy for me to get in that discussion. I fly a lot, and I usually wear headphones.
Yes.
If I'm reading a medical journal, hey, are you a doctor? And you get into these cholesterol discussions, and I usually have work to do on planes. So, but this is another one of these old fallacies now. And it derives from the fact that all the autopsy studies early on of people dying of heart attacks, when they look at their arteries, they were full of what's called plaque. That's pretty much a collection of cholesterol in your artery wall. So, my God, that's what causes heart disease. It's cholesterol. Well, you know what? That's true if cholesterol gets into your artery wall. But what is the relationship between cholesterol in your artery wall and cholesterol floating around in your bloodstream? Believe it or not, it's not as linear as you might believe. And we've known that from the earliest epidemiological studies. Most of you may have heard of the great Framingham heart study. It's still going on in the United States. It started after World War II, where they knew, wow, we got this epidemic of arteriosclerotic heart disease. Maybe we better look into it. And they just started doing physicals in people outside of Boston, Massachusetts, and they followed them longitudinally over time and measured a lot of stuff, including cholesterol in the blood. And before you know it, it said, wow, there is an association between cholesterol and atherosclerotic heart disease. That's the headline.
Yes.
But if you look at their data and you look at the distribution of cholesterol in that population, it's a bell-shaped curve. So in other words, these are all people with heart disease. How many had low cholesterol, middle-of-the-road cholesterol, nightmare cholesterol? Well, most people had middle-of-the-road cholesterol levels that, not too bad, but they got heart disease. And there were some people with very high cholesterol levels who had heart disease, but there was an absolute equal number of people with low and perfect cholesterol that got heart disease. There also were people with high cholesterol who got no heart disease. So the answer, once you look beyond the headline, was, whoa, this is a lot more complex. And it's a lot more complex than saying fat causes heart disease. And the same is true of cholesterol. So what that means is we're going to have other biomarkers or tests that tell me irrespective of your cholesterol, are you the guy that's going to get the heart attack?
Yes.
And if not, why do I even care about your cholesterol? Once you understand that, we get into the complexities back to nutrition. Oh, if it's cholesterol in your arteries, by God, don't be eating cholesterol, because surely it's going right into your arteries. And I hope we can get into it today.
Yes.
I will assure you the amount of cholesterol in your diet, I mean, unless you're eating 42 pounds of it, has nothing to do with atherosclerotic heart. Many guidelines are even starting to take cholesterol restrictions at least out of their guidelines, because they know the studies don't support that. Even though the famous 7-country studies suggested it, please go read Gary Taub's books on proper analysis of those trials. So right away, we've introduced a whole bunch of enigmatic questions here. Geez, it's not fat, it's not cholesterol. Measuring cholesterol in the blood is surely not your pathway to immortality. What's going on here? It's got to be something.
It's got to be something, and that's going to bring us to the particles.
Yes.
I mean, doctors to this day that I interview still don't separate LDL and HDL. They say LDL cholesterol, HDL cholesterol, and that's a very tough association to make, especially since it's not a cholesterol.
Yeah, you're impressing me right away, Michael, because you're at least using the proper terminology when you talk about what the heck we're looking at. So let me just get into a little scientific discussion that you don't have to be a brain surgeon to understand, relating lipids, lipoproteins, and atherosclerosis. We've already discussed that if you have cholesterol or any other sterol, and cholesterol is a sterol produced by animals, but we eat a lot of plants. They can't make cholesterol, plants, but they need a sterol. They make a whole bunch of things called phytosterols, which structurally look very similar to cholesterol. I don't see any roots coming out of your speakers. You're not a plant, so you don't make phytosterols, but I bet you eat them. And I know you eat cholesterol, and I will guarantee you that every cell in your body makes cholesterol, because it's an absolute essential molecule for human life. No cell could exist without cholesterol, because it's an integral part of the cell membrane. So the good Lord, evolution, whatever you believe, has made sure every cell can produce cholesterol. All right, so you really don't have to eat it. You will not die of cholesterol deficiency if you're eating zero cholesterol, because your body will make it. But if you have cholesterol or a phytosterol in your arterial wall, you have atherosclerosis. I can diagnose that, add it to your medical record, and know that, you got atherosclerosis. I hope you don't go on to develop an obstruction, so you need a bypass or a stent. Or I sure hope that plaque doesn't explode, setting off a clot in your arteries, which would kill you pretty instantly. If it doesn't kill you, you just survived your heart attack or stroke. So it all comes down to, okay, if cholesterol in the artery wall is what is necessary to have the disease atherosclerosis, how did it get there? Let me assure the listeners here, nobody's artery is over-synthesizing cholesterol and building it up over 30, 40 years of your life. That does not happen. So, I'm from New Jersey. I've gotten a lot of mileage out of this. Atherosclerosis is simply an illegal dump job of cholesterol in your artery wall. We Jerseyans know about illegal dumping. So if something carrying cholesterol in your bloodstream decides for whatever evil reason to, I'm going in the artery and dump it, you've got atherogenesis. If whatever's carrying cholesterol in your blood decides, I'm not going to the artery, let me take this cholesterol somewhere else, guess what you're not getting? Atherosclerosis, because there would be no illegal dumping of cholesterol in your artery wall. So this comes back to biochemistry then. Lipids, and cholesterol is within the family of molecules called lipids. A lipid is defined as a molecule not soluble in water. It would only be soluble in an organic solvent, alcohol, benzene, something like that. Well, the last time I analyzed every human, their bloodstream is basically water. It's an aqueous solution. So lipids, like cholesterol, like fatty acids, 3 fatty acids stuck together on a piece of sugar called glycerol is a triglyceride. They're all non-water soluble. I can assure you there's not an animal on the planet Earth walking around with free cholesterol molecules, free fatty acid molecules, or free triglyceride molecules in their bloodstream, because that's a physical chemistry impossibility. But I know there is cholesterol in your bloodstream, right? You can have it measured. I know you can go get your triglycerides or fatty acids measured in your bloodstream. You would say, no, Tom, they're in my blood. not as free molecules, they're not. So the only way lipids are trafficked in human plasma is they have to be attached to a protein. Yes. Proteins make anything water soluble. So most of the things in our bloodstream that are not soluble in water are attached to a protein. Fatty acids can attach to a protein called albumin, and although you don't have many fatty acids in your blood, it's really free fatty acids are attached to albumin. All of the other lipids in your bloodstream, be they cholesterol, if I stick a fatty acid on cholesterol, it's called cholesterol ester. If I stick 3 fatty acids on glycerol, triglycerides. There's another way of trafficking lipids called phospholipids, where some lipids bind to phosphorus. Phospholipids, triglycerides, cholesterol, and cholesterol ester, the only way they go anywhere in the human body is they are passengers inside a protein-wrapped vehicle called the lipoprotein. So it is so crucial. If I was doing an address to a community group of physicians or a high-level group of physicians, they must understand that lipids go nowhere in the human body unless they are a passenger, unless they are being trafficked by a lipoprotein. You don't have to be Albert Einstein to realize, well, if that's true, that all the cholesterol in my blood is inside a lipoprotein, the only way an illegal dump job could occur is if a lipoprotein carrying that cholesterol crashes into my artery wall instead of bringing it back to some organ that can utilize it or get rid of it, my liver, my gut, some other cell in my body. Aha! So atherosclerosis is cholesterol in the artery wall, but it is mediated totally, no ifs, ands, or buts about it, by lipoproteins. So now the next question is, okay, I buy that, that's reasonable, and trust me, I can show you study after study, be it in an animal or in humans, that's what's driving atherosclerosis. You would want to know 2 things. Well, what are the types of lipoproteins in our body? Do they all have the capability of doing that illegal dump job, or do only some of them have that capability? And if it is lipoproteins that are doing this, how would I best use the laboratory to assess what is my chance of having illegal dumping of cholesterol in my artery wall? And trust me, that's going to come down to lipoprotein analysis. And the better the test is on identifying lipoproteins, that's the test you ought to be doing. For years, we only had the technology and the reproducibility to measure cholesterol in the blood. And in these people, that if we go back, who are the people with cholesterol abnormalities who get heart disease? They all have the wrong type of lipoproteins in their blood. Who are the people with high cholesterol who never got heart disease? They don't have the wrong type of lipoproteins in their blood. Who are the people dropping dead, like Tim Russert of NBC fame, with perfect, almost childhood LDL cholesterol levels? Well, he had the wrong type of lipoproteins in his blood, despite his pretty good cholesterol measurements. So by analyzing lipoproteins, you can take it to the next level. And lest you think this is, wow, this is a radical cutting-edge guy, absolutely not. Lipidology got introduced to the medical community in the 1960s. They actually discovered lipoproteins in the late 1940s. Actually, some nutty physicist with a lot of time on his hands, instead of putzing with radioactive particles, stuck some blood. You know, physicists use ultracentrifuges all the time. So he put some blood in there, and what are these things? And he discovered lipoproteins. It took them another 10 years to figure out what they were and what they did. So finally, 3 phenomenal, basically the godfathers of lipidology. Don Fredrickson, Robert Levy, and Lees put together this classic 5-part treatise in the New England Journal of Medicine. For those not physicians, the New England Journal is like, wow, the ultimate thing to get something published in, you know? They try and go with the science as it really is. So in their 5-part treatise, and I like to point out, I don't believe since the New England Journal has ever done a 5-part treatise on any aspect of human health care, they introduce the concept of lipidology to the American physicians. And here's what they said. They begged physicians in the year 1967, when these got published, to stop using the term hyperlipidemia, too much lipids in the blood. Dyslipidemia, some people call it, abnormal lipids in the blood, and abandon those terms and start using hyperlipoproteinemia, too many lipoproteins in your blood, or dyslipoproteinemia, the wrong type of lipoproteins in your blood. Because they thought once we focused on lipoproteins, this is an easy disease to understand, it's an easy disease to eradicate. I don't have to know anything about you maybe, what you're doing, what you're not doing. I need to start with a lipoprotein analysis, and if I determine you're at risk, then of course I would be interested in your nutrition, your activity, anything else you're doing. But to start with, I just have to know, do you have illegal dumpers floating around? Now, of course, in '67, the only way to separate lipoproteins was something called the preparative ultracentrifuge. It's a 24-hour test, immense technology. That's not a test applicable to doing 20 million lipid analyses on human beings. It's impossible. So it did take another 30 years for the biomarker industry to develop readily, easily done overnight tests that can quantitate lipoproteins. Unfortunately, we're in that world now. Back in '67, they said the only reason we've been doing cholesterol measurements is because the technology exists, it's very reproducible, it's cheap, but we're using cholesterol concentrations as surrogates, predictors of do you have the wrong type of lipoproteins. You know, and there's a correlation. In many patients they do predict, but the problem is in many patients they don't. And there's a concept that if you're going to discuss this with your physician, you must be aware of. When two laboratory tests or biomarkers correlate with an outcome that you're trying to prevent, they are said to be concordant. And if that concordance is high, it doesn't matter which test you use. They're both wonderful tests. However, if in patients one test predicts it and the other test, although it may predict it, it doesn't apply to every single patient, they're said to be discordant. So in the people getting heart attacks with normal LDL cholesterol but high lipoprotein concentrations, which one do I believe? Well, we have enough studies that show risk always follows lipoprotein measurements. So when the two measures that normally correlate do not, they're said to be discordant. So if you have discordant cholesterol measurements and lipoprotein measurements, I bet your life on the particle measurements, not the cholesterol measurements. And any number of studies showing that. We have 5 societies in the United States, specialty societies, that have signed on to lipoprotein testing in addition to lipid testing. So this is the key. So if you came to me as a new patient, I can't just say I'm going to screen you with cholesterol, and then if it's high, then I'll do the lipoprotein test. Because what if it comes back normal? What if you're Tim Russer? And I say, wow, Tim, you're a little chubby, but your LDL cholesterol's phenomenal. Get the hell out of here. And I would attend his funeral down the road a little bit and explain to Mrs. Russer, I'm sorry, he's had wonderful cholesterol levels. Whereas, had I done a lipoprotein analysis, I would have said, you know, I'm happy you got nice cholesterol levels, but it's irrelevant. You're at nightmare cardiovascular risk because you got too many of these illegal dumpers who are going into your artery wall. So this is some of the why you have to just do the particle measurements, because you just can't say, oh, look at my wonderful cholesterol levels, I'm home free. What if you're a discordant person? And how would I know that without doing the lipoprotein measurements? I wouldn't. I can't look at you. You look like you're in good shape and damn. You want me to tell you how many world-class athletes have had heart attacks? You want to tell me there are couch potatoes out there for whatever reason are not dropping dead of heart attacks or so. In general, more of them are than you, but there's exceptions to the rules. And if you come to me for one-on-one care, you don't want me to roll the dice and flip. You say, please, we're in 2002, do the best possible blood tests or markers of risk with this disease so I can then discuss therapy with you. So if lipoproteins are mediating atherogenesis, we must measure lipoproteins. Now, real quickly, lipoproteins discovered by their physicists in an ultracentrifuge separated by their buoyancy. You know, big balloons float higher than little balloons, you know. So the bigger a lipoprotein is, the more full of lipids it is, lipids float. If you are a small lipoprotein, you have very little lipids, you mostly got a lot of those proteins wrapping it, proteins are heavy, you sink. So in a centrifuge, lipoproteins got their name. Very low density floats on top. High density sinks to the bottom. In between are low density or intermediate density. So that's where they got their names. And everybody in today's world says, yes, I've heard of them. Low density lipoprotein, high density lipoprotein. Isn't low density cholesterol the bad cholesterol and high density cholesterol the good cholesterol? I wish it was that easy. Yes. The graveyard is also full of people with high HDL cholesterol. Many of them are women, and there are some people with low HDL cholesterol who are not at any risk for heart disease. So that's going to be another cholesterol test that can let you down big time. So those are your lipoproteins. A better way of analyzing them in the year 2012 is, let's look at the proteins that wrap them and give them their structure, stability, and solubility. And although there are several, the two key proteins that give these particles their structure is on HDL particles, the protein is called apolipoprotein. Apolipoprotein is a protein that sticks on the surface of the sun. Apolipoprotein A, capital A, -1, Arabic 1, Roman numeral 1, whatever you want. So if I measure ApoA1 on you, I'm sort of counting how many HDL particles are in your bloodstream. If I measure HDL cholesterol, what that number tells me is if I could take every HDL particle that's floating around 3 ounces of your blood, that's called the deciliter, what is the mass, what is the weight of all the cholesterol molecules they're carrying? So HDL cholesterol tells me all of the HDL particles in a deciliter of your blood are collectively packing 45 milligrams of cholesterol. All right. One would be the number of HDL particles, the number of dump trucks. The other would be what's in the back, how much cholesterol they're carrying. That's your HDL story. Every other particle in your body, the structural protein is apolipoprotein B. And there's one ApoB on every VLDL, IDL, and LDL particle floating in your body. So if I measure ApoB, I'm collectively counting VLDLs, IDLs, and LDLs. Not really, because it depends on the half-life. A VLDL particle, which takes lipids out of your liver and delivers them to muscles and fat cells, 2 to 4 to 6 hours. They get their lipids removed, they shrink, they become an IDL, an intermediate density lipoprotein. Most of those are cleared rapidly by the liver, but at the liver, some undergo exposure to other chemicals that reduce the lipids, and some of your IDLs shrink down and become your LDLs. The half-life of an IDL is an hour or 2. The half-life of an LDL particle is anywhere from 2 to 5 days, depending on its size. Bigger ones get cleared quicker than smaller ones. So if that's true, the LDL half-life is measured in days. Those other particles are measured in minutes to hours. 90 to 95% of your ApoB particles are LDL particles. So when you go to the lab and get an ApoB level, understand that's basically an LDL particle count. There are other technologies that will quantitate the particles. The one most of us use throughout America is nuclear magnetic resonance. What they do is they take your blood that has your particles in it, they expose it to magnetic waves which sort of oscillate the lipid groups in air, and from those oscillations they can translate it to a particle count. You don't need to know the ifs, ands, or buts on the technology. So those are the two ways of getting your LDL particle count. The NMR can also give you an HDL particle count. You would have to do ApoA1 if you want to count HDLs via apoproteins. So again, LDL particle counts is the number of LDL particles floating around your bloodstream. LDL cholesterol would be, if I take every LDL that exists in 3 ounces of your blood, a deciliter, collectively, what is the mass of the cholesterol they're trafficking or transporting? And why doesn't, if that's true, you would say, wait, if you have a high LDL cholesterol, you have to have too many LDL particles. If you got a low LDL cholesterol, you can't have many LDL particles. What always sounds simple in medicine turns out to virtually never be true, and here's the reason. 2 people come and see me. They have, let's say, a perfect LDL cholesterol level, but I've done both tests. One person has a nightmare, very high LDL particle count. The other person has a perfect LDL particle count. How is that possible? How could you have such a low LDL cholesterol and have a lot of particles? And it comes down to how many cholesterol molecules can be in each particle. All right, what if one person had really small LDL particles and the other one has big balloons as LDL particles? Everybody probably took high school physics or geometry or whatever. The volume of a sphere is pi 4/3 radius cubed. It's a third power of the radius. So even a subtle diameter change translates into a humongous volume change. Everybody is startled to hear that it takes the volume of 16 marbles to fill the volume of one ping pong ball. You would think, oh, what's it take, 3 marbles to fill a ping pong ball? It takes 16, and that's because you're cubing it. And you just don't realize what squaring or cubing something does to the numbers. They go up astronomically. So here's 2 people with a perfect LDL cholesterol. The guy with the small LDL is going to have 40 to 70% more LDL particles. It takes a lot more small dump trucks than big dump trucks to carry a given mass of anything. If I had a mountain of dirt outside that we had to move, how many Nissan pickup trucks would it take to move that mountain of dirt compared to earth-moving dump trucks? I'd need a hell of a lot more Nissan pickup dump trucks. The particle number would be higher there, and that's how you die with normal LDL cholesterol. But to bring this into why carbs are going to be so crucial, is there another reason that would explain that discordance? And it would be. Suppose somebody comes to see me, both perfect cholesterol levels, one again a nightmare LDL particle count, the other a perfect LDL particle count, but they both have big LDL particles. There's not small particles. Now, a physician would say, oh, I don't buy that. If you got too many LDL particles, since they primarily carry cholesterol, you'd have to have a high LDL cholesterol level. And that would be true if your LDL particles were carrying cholesterol like they were supposed to. But what if through some sneaky mechanism called human pathophysiology, your LDL particles weren't carrying cholesterol, they were carrying fat instead, triglyceride. What if you had a fat LDL? Well, it's a big fluffy buffy LDL, which some people still are saying, oh, if you have fluffy buffy LDLs, you can't die. Want to bet? If your LDLs are packing triglyceride molecules, guess what they're not packing? Cholesterol molecules. So that big fluffy buffy LDL would be very cholesterol depleted. A small LDL is very cholesterol depleted because it can't carry much, it's small. So even though they got big LDLs, their LDL cholesterol level would look wonderful, their LDL particle count would be a nightmare. If we were just measuring LDL triglycerides, which other than that's just not a test available outside of research labs, we would know that in a nanosecond, saying, you're the person where the most important blood test is not LDL cholesterol, it's LDL triglyceride levels. But until that becomes available, you can't do that. And since I can now count particles, I don't have to know anything about the lipids inside your particles, do I? I just have to know, do you have too many or not? And the one caveat here is, you now know you separate lipoproteins by their density or by their apoprotein content. And that's easy, because then you're into 2 families of lipoproteins, ApoB and ApoA1. Here we go. The only illegal dumpers are your ApoB particles. They are the ones that, if they crash your artery wall, they get stuck in the air, white blood cells eat them, the white blood cells fill up with cholesterol, you got plaque. HDL particles go in and out of your artery wall all day. They never get stuck there. They never get eaten by white blood cells. They are not doing illegal dump jobs. The ApoB particles are. And if you've listened to me and you know in the vast majority of people, 90 to 95% of their ApoB particles are LDL particles, the illegal dumper is LDL. But what makes the LDL be an illegal dumper? Normally in LDL, if you produce the proper amount, it's supposed to go out, it actually acquires some cholesterol and it brings it back to the liver. That's what LDLs do. But if you have too many LDLs, the liver can't clear them. They got to go somewhere. You got miles and miles of blood vessels there, and hey, let's go park in there. So what drives an LDL into the artery wall, what drives an ApoB particle into the artery wall is particle number. What has nothing to do per se is the particle going into your artery, whether it's big or small, and whether it's got a ton of cholesterol in it or almost no cholesterol in it. And to just show you, a big LDL that is cholesterol rich, as LDLs can be, might carry 3,000 molecules of cholesterol, but a small LDL or a big LDL packing triglycerides might only have 1,500 molecules of cholesterol. So, you know, it's particle, your LDL cholesterol might look pretty good if there's only 1,500 molecules of cholesterol per particle, even if you have a lot of particles. But your particle number, every one of those LDL particles is probably going in your artery wall. So if you just sit down, maybe we listen to what I've just told you, that is not, I'm basically talking big dump trucks, little dump trucks. I'm really talking about how many dump trucks are carrying lipids.
Yes.
And I hope they're not the ApoB type of dump trucks, because then you're in trouble. If you are in trouble, you had your heart attack, or I do the proper measurement and your ApoB or LDL particle count is high, I dismiss your lipid concentrations, what do I care? Then I've got to try and see, geez, I know your genes are your genes. Right now I can't putz with them. That's probably coming one day, but not yet. Therefore, is there anything in your environment that's affecting your particle counts? And now we're back to nutrition, exercise. What the hell are you consuming either from the health food store? And trust me, not everything you take out of there is, I would not believe too many labels in there. Or, you know, are you on some drugs that I don't know about or so? And there are drugs that aggravate particle counts. Drugs that might have very legitimate indications. You know, remember in the old days in America, we had a lot of lunatic asylums here.
Yes.
Nowadays we don't have as many because we have great psychopharmacology that gives these people a degree of sanity. Many of those drugs screw up your particles. So they keep you out of the lunatic asylum, but now we have to go in and make sure we're not giving them a heart attack instead of their lunacy. And there are other categories of drugs that do that. So now it becomes, wow, so I have to take a detailed drug history, be it a food supplement, an over-the-counter drug, or a prescription drug, and say, if you do have bad particles, could any of these drugs be contributing to it? And if they are, do you really need those other drugs? Or if you do need them, then I have to sort of get an antidote to those drugs. So it becomes so simple when you're counting particle numbers. We could go beyond that. If you had too many particles and they were building up plaque in your arteries, is that plaque inflamed? I can measure markers of inflammation in your blood. God forbid that plaque ruptures, you're going to clot. Do you have sticky blood or not so sticky blood? We can have platelet tests. So you can see all of a sudden, once I have the particle number, I'm not done. There are other things I'd want to know about you that would further define your risk. But I think in today's world, and you know, we have something in this country called NHANES, the National Health and Nutrition Examination Survey, where every year they take thousands of Americans and they run like every blood test in the world on them, so we keep a handle on these things. And we sort of learn what risk factors are evolving and what not. And one of the most recent analyses of that suggested 80% of heart attacks, bypasses, angina in the United States right now are not because you got some familial genetic lipid lipoprotein disorder. It's because you're insulin resistance.
Yes.
So if we could start to understand insulin resistance better, thank you, Gary Tobbs, thank you, Peter T, and Bob Lustig and geniuses like that, maybe that's the whole damn answer. Maybe a guy like Dayspring doesn't have to write 5 lipid drugs to everybody if he had a better handle on nutritionally what could be done to his patients. And unfortunately, for most of the lifestyle, I believed all the old dogma, stop eating fat, stop eating fat. It's funny, there were still a lot of heart attacks occurring and stuff, and you know, so anybody who had the goal to question it would have said, I don't know if that's true with everybody. And guys like Tobbs came around and did not only post those hypotheses, but went out and analyzed the data and show, you know what? And the thing that drives insulin resistance in human beings is carbohydrates in the diet, on top of your genes, of course. And most of us are not blessed to have perfect genes. So when we evolved as a species, Gary goes into this, we just did not evolve the genes to fight carbohydrates. Because in the millions of years of our existence, or our predecessors' existence, carbs were not a staple in the diet. You know, the paleo guys know that. So when did carbs introduced? When agriculture sort of got invented. Oh, guess what appeared in the evolutionary scale when atherosclerosis was not a disease before agriculture. Agriculture meant corn primarily, and you know what's in corn. God, there's a few carbs in there, you know. So that's what drives fatty acid production. That's what drives triglyceride production. And if you've got fat and triglycerides in your liver, you're going to produce ApoB particles that become LDL particles. But because they're smaller, they're carrying triglycerides, LDL cholesterol may not be reflected. And the last thing I'll say is any doctor knows, doctor, what is the lipid pathology you see in your insulin-resistant type 2 diabetics? Oh, it's high triglycerides, it's low HDL cholesterol, but LDL cholesterol really doesn't matter. You could be a nightmare diabetic and have a normal LDL cholesterol. It might be high. It doesn't help me. But when we diagnose metabolic syndrome, it's not one of the criteria. So the doctor sort of understands it's not LDL cholesterol in diabetics. They know it's something. They sort of don't believe it's the triglycerides. They do believe, it's probably related to low HDL cholesterol, but I don't know how to change that. And they just don't know it's the particles. The last thing I'll say is, you know, James Carville got Bill Clinton invented by running around saying it's the economy stupid, it's the economy stupid. Made sense, everybody believed it. Well, for years, doctors have been running around saying, you know, it's the cholesterol stupid, it's the cholesterol stupid. You know what? It's the particles stupid. It has nothing to do with the cholesterol. So I took a lot of time here, but I hope you can watch this at your convenience and start to understand the pathology behind why you need an ApoB or an LDL particle count. And they're going to always do your lipid profile. It's not like a lab is going to do LDLP or ApoB without also doing the lipids. I mean, if you told them to do that, they would. But you'll get both together. But when you do, they all bring something to the table. But what really brings everything to the table is your atherogenic particle counts, ApoB or LDLP.
That's fantastic. Just a couple quick fire questions I
Sure.
have for you. I debated an NYU nutritionist, and she was convinced that you needed the carbohydrates in the diet because if you go into nutritional ketosis, it's very damaging to the system. Based on what, I don't know. What's your feelings on ketosis?
And she's saying that because everything she's ever been taught in nutrition school has suggested, God forbid you eat fats, and God forbid you do that Atkins thing without carbs. You're going to form ketone bodies in your blood, and your pH will drop a little bit, and they make up all these horror stories that ketosis going to occur. It's just not true. You know, the real reason you need, everybody thinks you need carbs, is what drives your brain is glucose. Glucose is what your brain needs. You know, you get acute low blood sugar, you're going to become unconscious real quick. You wouldn't if you had a high ketone level in your body, because our brain can use ketones as energy and whatever our brain uses that for, as well as you can, by looking at some data, suggest ketones are even preferable. And there are certainly people right now doing research to say people who are ketogenic, have ketones in their body, may get less dementia as time goes on and everything. And that is a very viable hypothesis. So she's dead wrong that ketones are going to harm you in any way. They're not. You also know that the people who go on low carbs, it takes some serious low carbon to make yourself ketogenic. Most people who are going to only partially restrict their carbs are not going to become ketogenic. So what is her criticism of that then? Those who really want to drive themselves into ketosis, because there are many people who believe that's fine, I don't think she can come up with any credible evidence that that's harmful to human or is associated with any human disease, other than, well, that's what my professor taught me. And you go and analyze the study, and it's a useless study, and nobody is better than Tobbs at taking those study to pieces. And I beg anybody who might be listening to this on the internet or wherever and say, listen to this lunatic here, and you got to view with suspicion anything you're getting over the internet. I beg you to open-mindedly read. Start with Gary Tobbs' Why Do We Get Fat book. That's the most readable. He's got a much thicker book of a few years ago, Good Calories, Bad Calories. But I think you need some degree of education before you go to that. Just read that with an open mind. and see that just everything your nutritionist and probably your doctor has been telling you is the same thing the doctors who used to bleed people to say your lives told you. Oh, in medical school our professors taught us this is how we cure disease. Are you questioning me? And thank God people eventually question him. How about they used to throw young students out of medical school, surgery school, who washed their hands prior to surgery because they somehow listened to the guys who discovered bacteria and stuff, but they were shunned. You lunatic, get out of here. So things change in medicine, and I will just tell you, much of our nutritional dogma is hardly based in serious scientific trials. They're tough trials to do. The right trials have never been done, and fortunately there are people now who are at least finally. We have a brand new institution started that's going to be well funded in this country by Gary, Peter, Attia, that are going to be doing these proper type of studies to answer these questions once and for all. So, you know, but when you go to a modern nutrition or even a doctor who's oblivious to these new data and biomarkers, everybody falls back on what they've been taught. And the real key in science, anybody who's in a science profession and thinks, that's it, I've got this mastered, I know it all. God, get out of science, please. There's no such thing as truth in science. Truth is what the best evidence supports today, realizing it's going to change as we get even smarter. Deeper we delve into human physiology, we'll have better ways to do it. But can we all move on? I like to joke. I graduated medical school in 1972. Where it went, I don't know. But if I practiced medicine the way I was taught in a very good medical school, I would be arrested nowadays. I would lose my license. I would be hiring lawyers like crazy. I can't tell you how many FDA drugs I wrote back then that were absolute toxic poisons. But at the time, they were the best evidence that what a brilliant internist Dayspring is. He's giving you the best stuff. Fortunately, when newer studies come out and shut down the old stuff, like the guys who started washing their hands, like the guys who stopped the bleeding, they moved on. Most of my life, I've been trying to ascertain your cardiovascular risk with cholesterol measurements. It's better than nothing.
But yes.
But now that I'm here, why do I want to go back? No.
So the case could be made that it's probably safest to actually eat more fats if you're trying to reduce their body fat, then even higher, because what they'll do is reduce the carbohydrates and reduce the fats, and then eat tons of protein.
Yes, and now, but I will make the caveat, and that's if we're talking about an insulin-resistant person here. If for some reason you had zero genetic insulin resistance, I doubt that the carbs matter to you. You can eat your M&Ms all day long and suffer or your white potatoes and get no harm from them. But that's a real minority of people who have no genetic. The people who have horrific insulin resistance, like Asian Indians and other populations, American Indians, they're skinny. India's a vegetarian country, but they have the highest incidence of diabetes of anybody. So even a little bit of carbs to somebody who's got a nightmare genetic profile sends them down the wrong metabolic route. So there could be a sumo wrestler who's got perfect genes, and you know what? He's blessed. He picked the right mom and dad. Most of us did not. I take that back. We all picked the right mom and dad, but not genetically speaking. So if you're talking about insulin-resistant people here, yes. If I eliminate the carbs, guess what? Your pancreas stops making insulin. And without getting too deep, and just read Gary Taub's book, he'll take you through the pathways. Insulin is what drives fat into your cells. And not only does it drive fat into your cells, it locks it there. So if I lower my fat, but therefore replace it with carbs, as the food pyramid tells you to do, all I'm going to get is fatter and fatter and fatter, even though I'm eating less and less fat. Now, there have been some diets where, they've lowered their fat and they did good. Virtually anybody who's obese who goes on a low-fat diet is drastically lowering their carbs at the same time. And what we attribute the benefits to, of course you ate less fat, when it had nothing to do with it. It's the carbs that you're eating a lot less of that just saved your butt. Go back to enjoying your fat. Have some bacon and eggs once in a while. Have the burger without the bun, and you're not going to drop dead because of that if you're insulin resistant. And I know nutritionists are feigning who might be, except not the progressive nutritionists. You know, here at Health Diagnostic Labs, we have a small army of what's called healthcare coaches. I think they're going to start calling them healthcare consultants. But these are modern nutritionists trained on modern biomarkers and know how to individualize the nutritional therapy. We're doing not only lipoprotein analyses on you here, I would do numerous markers of insulin resistance beyond a sugar level that would tell me, I know your sugar's good, but I hate to tell you this, within 15 years you're going to be a full-blown type 2 diabetic if we don't improve these markers. And there's no prayer to improve them without some serious drugs, which you probably don't want to take, you would if you had to. If I could just say, let's do this nutritional adjustment. Read the damn labels. Stop eating these carbs. There's a particular carb called fructose. Avoid it like you would the plague, for God's sakes. In America, can you go into a supermarket and buy anything in a box or a can that doesn't have fructose in it? No. We'd have to shut down the states of Iowa and Illinois if we're going to ban fructose, these corn grinders.
Yeah, there's no way.
So this is so fascinating, and please, for your own benefit on your investigations, your annual physicals, get a particle count in addition to everything else. And then you can attack it nutritionally or so. And there are plenty of more modern nutritionists. And I'd look real suspicious, even if a doctor correctly diagnosed insulin resistance and he says, yes, you have lipoprotein risk, or let's get you over to the nutritionist because lifestyle is so crucial. Unless you want me to start giving you 3 or 4 drugs, I'll be happy to do that. But who wants to take 3 or 4 drugs if you don't have to? Look, I'm not anti-drug. I'm all for drugs for the people who need them. But if I could solve something with some easy nutritional changes, it'd be a lot cheaper, it'd be a lot easier. And I think if we fight insulin resistance, I'm not only going to help your heart, your brain, your prostate gland, your colon, because several cancers are related to insulin resistance. God knows what I'm going to help. Maybe your joints. So if you go to that nutritionist, your doctor's properly diagnosed you, and he punts to the regular routine, old time I call him, nutritionist who says, let's get the fat out of your diet. Say, you know what? I got an appointment somewhere else. And run, don't walk. You know, please. And there's enough material out there nowadays for you to just do the homework yourself and see what's true and what's not.
Is there any other trailblazers out there that you think we should talk to, besides obviously Tabs, yourself?
No, yeah, it's kind of funny. We all hang around with the type of people who sort of pat each other on the back and tell us how smart we are. So there's a lot of people out there that can give you further insight in the lipid and lipoprotein world, and as well as in the nutritional world. When you talk about Tabs and Atia, you're certainly in the people who have challenged conventional thinking. There are no 2 better ones doing that or so. There are obviously others, and there are others more established in the medical community. Bob Lustig out there has written. But you know, some of these highfalutin, high academics are not the easiest guys to get into. At my stage of the game, I do share time with associations like this and other people. Some of you know Jimmy Moore. I've done his radio blogging. And because I'm, you know, you learn with wisdom. I learn I can influence way more people by things like this than I can go into a medical convention talking to a handful of doctors, half of which will, what a lunatic he is, you know, and half might look into it or so. So there's many ways to skin a cat. So I think it's probably wise for you to, hey, I'm a big MD, I'm a very well recognized lipidologist, have that respect, so you have me, I can give you other names there. But you got to get the right people in the nutritional community too. You know, very recent, at last year's annual meeting in the National Lipid Association, Gary Taubes came and addressed. And this is wonderful because organizations, professional medical organizations, have always considered guys like him the internet lunatics or something. Because we're not bringing him to our convention and spout, you know, what's against the dogma. But those of us in the lipid community who have clearly gone through this evolution, abandoning our golden cholesterol measurements, are much more open-minded. And they brought him down. They had a conventional nutritionist talk, and you had Gary talk, and the audience can then make up your mind and read the various references or so. And Gary won that debate very easy at the society. You can't. It's kind of tough to debate somebody who really is well versed in the facts as we know them now and the physiology and everything. So there are other people out here. Even here, we could probably hook you up with some coaches, nutritionists who might, and they can bring like, hey, here's a nice magazine with, and they can delve into the specifics. You know, it's an art to walk in the store and know what's got carbs in it and what doesn't. Even when you think you're in the healthy vegetable or fruit part of the station, that's you know what's good in there and what's not. What are your packaged meats and stuff? Are there any carbs in any of them or stuff? Are nuts all bad? Are some nuts good? So you do need nutritional counseling if you want to, if you're insulin resistant, you want to reduce carbs in your life and everything. The last great thing that has come from this, and if you're looking at me, you can see I'm packing a few extra pounds, but if you saw me a few years ago, I would have been a lot, they didn't need a much more wide-angle lens to film me or so. And, you know, it's kind of funny. There have been periods in my life where you go up and down as a yo-yo. Years ago, somebody introduced the Stillman diet, which is basically the forerunner of the Atkins diet. And I know I lost weight like crazy on that. I'm this brilliant guy, right? I just never figured it out by myself until I read Tom's book. So thanks to Gary, I've lost so I obviously have some more to go. I'm not in a ketotic state right now, but I'm doing very well with that. And you know, numbers that used to take a bunch of drugs in me, no longer take them and everything. So it's just the way you got to go. But for all my life, anybody who looked at me and, wow, you're doing a lipid lecture, you know, it's basically, you fat slob, why don't you take care of yourself? Why don't you eat less fat and exercise a hell of a lot more? And you shared an anecdotal story with some of the people in your gym. They all come in, obviously they're working like hell, but not all lose weight at the same amount, and some don't. And what? Hey, I'm working out like Jungle Jim here. Why aren't I losing weight? Because when they're done, they're drinking their carb beverages, their sports drinks, and you'll never lose weight because those calories are going to be sent right to your fat cells. They never come out. So not every fat slob is a fat slob because they don't care or they're not trying to watch their diet. We're following the American Heart Association diet, which has said stop eating fat. And yet every time I go to the store and buy something that says low fat, I never read what the carb is in there. It's through the roof. I'm going to get ugly here. May he rest in peace. Senator McGovern just died this week. He is one of the foremost patriots the United States has ever produced, a World War II hero of immense magnitude. But let's face it, most things that come out of Congress really screw us up. And unfortunately, he was in charge of the committee way back when, 30 years ago, that inverted the food pyramid and said, based on the faulty studies that we've alluded to, we've got to take fat out of the American diet. And if you're taking fat out of the American diet, you have to replace it with something. And they replaced it with grains, potatoes, rice. And all they did was make America the fattest country on the planet Earth and the most insulin-resistant country, and lipoproteins. Have we closed any CCUs in America since we've advocated low fat? Have you seen cardiologists at the unemployment office, bypass surgeons saying, what am I going to do? No, they're not. We can't produce them fast enough. And trust me, a large part of that is this low fat, therefore high carb diet. And be open-minded when you study this stuff. But please get your particle counts.
Absolutely. And I don't want to take any more of your time. This was unbelievable. We appreciate it. Hopefully we can set up another one in a couple of months.
Yeah, I think once you understand these basics, getting into a little more specifics, we didn't talk about low HDL cholesterol so much today, but I sort of hinted to you that one cause of low LDL cholesterol is your LDLs are fat or packing triglycerides. Well, an HDL should never carry fat or triglycerides. But what if your HDL particles were carrying triglycerides? Guess what? They're not carrying cholesterol. You have a low HDL cholesterol. Until proven otherwise, low HDL cholesterol tells me you're insulin resistant. And the best way for me to raise your HDL cholesterol, if that's even necessary, I really just have to lower ApoB, would be to get fat, get triglycerides out of your system. Your HDLs would go back to carrying cholesterol. But no, I give you some drugs that raise HDL cholesterol. They've never been proven to do anything to heart disease. So the HDL story is very intriguing here
Article
too,
on
and trust me, it's all related to insulin resistance, which is caused by carbs, insulin, fat, and is there a medical term for fat? Triglycerides. And when you start putting triglycerides in particles that shouldn't carry triglycerides, your particles are going through the roof. And the next time we'll talk about what happens to the HDL particles.
Just so they know, the triglycerides are produced, if you drink a bunch of soda, your liver's going to pack them into
Triglycerides are 3 fatty acids stuck on a piece of sugar called glycerol. No glycerol, you can't make triglycerides. Glycerol is derived from carbohydrates. The number one carb would be fructose, is what drives, but others drive it also. Carbs can also drive fatty acid production. So carbs, too many fatty acids, too much glycerol, lots of triglycerides, tons of the wrong type of particles, but they're not carrying cholesterol. So I've got a wonderful slide I often end talks with, and it's in the graveyard. Sorry to be morbid here. And there's the widow on her dear beloved husband's tombstone. And born here, died here, and she's talking to her husband. We all talk to our departed ones, either silently or sometimes out loud. And she's saying, "Dear husband, your LDL cholesterol was at goal." And here he is, buried 6 feet under. So he probably was on a low-fat diet too.
Yeah, probably very low.
So it's a fun story, and we can do so much good. And please take care of yourselves.
I think this is going to further the talk and definitely get out to a tremendous amount of people. So really appreciate
can't
your
wait.
time, Doctor.
All right. Give me 5.
Thank you much.
All right, you can give it a go. I hope that plays well. That's kind
I
of
think
cool
so.
here. This is, I'm glad you came down in person.
Oh, yes.
It'll come across much better here than over the telephone.